When a patient presents with drooping of the eyelid, our first responsibility as optometrists is not to jump straight into examination, but to take a proper and structured history. A well-taken history itself can give us almost 50 to 60% of the diagnosis in cases of ptosis. Today, I'll explain how to take history in a ptosis patient in a simple, logical way. We always begin with the chief complaint, using the patient's own words. Ask when they first noticed the drooping of the eyelid. This single question helps us decide whether the ptosis is congenital or acquired. If the patient says it has been present since childhood, congenital ptosis should be considered. If it started recently, we think of acquired causes. Next, ask about the onset. Was the drooping sudden or gradual? Sudden onset ptosis immediately raises suspicion of neurogenic causes, third nerve palsy, or trauma. Gradual onset ptosis is more commonly seen in aponeurotic or age-related conditions. Then ask about laterality. Is the drooping present in one eye or both eyes? Unilateral ptosis often points toward aponeurotic, neurogenic, or traumatic causes. Bilateral ptosis may suggest myogenic or systemic conditions. This question helps narrow your differential diagnosis significantly. After this, ask about progression and variability. Is the drooping constant throughout the day, or does it change? This is a very important question. If the patient says the ptosis worsens by evening or improves after rest, you should immediately think of Myasthenia gravis. Fluctuating ptosis is a classic sign of neuromuscular disorders. Now move on to associated ocular symptoms. Ask specifically about double vision, eye pain, headache, or reduced vision. Ptosis associated with diplopia strongly suggests a neurological cause. Ptosis with pain or headache can indicate serious underlying pathology and should be treated as a red flag. Next, take a detailed systemic history. Ask about diabetes, hypertension, thyroid disease, or any known neuromuscular disorders. Also ask whether the patient experiences muscle weakness elsewhere in the body. Systemic conditions often play an important role in the development of ptosis. Past ocular history is equally important. Ask about previous eye trauma, eye surgery, or long-term contact lens use. Chronic contact lens wear can lead to aponeurotic ptosis due to repeated eyelid manipulation. Also confirm whether the ptosis was present since birth, which supports a diagnosis of congenital ptosis. Then take a brief drug history. Ask about long-term steroid use, neuromuscular medications, or any history of Botox injections around the eyes. Certain drugs can affect eyelid position and muscle function. Family history should not be forgotten. Ask if anyone else in the family has similar eyelid drooping. A positive family history may suggest congenital or hereditary myogenic conditions. It is also important to understand how ptosis affects the patient's daily life. Ask whether the drooping interferes with vision, whether they raise their eyebrows to see clearly, or whether they tilt their head back. These signs indicate functional impairment and are especially important in congenital ptosis cases. Finally, always be alert to red flags. Sudden onset ptosis, ptosis with diplopia, ptosis with pupil involvement, or ptosis associated with pain or headache require urgent referral and further evaluation. Always remember, ptosis is not just a cosmetic problem. Careful history taking helps us identify whether the condition is benign or potentially serious. A good history builds confidence, improves clinical accuracy, and makes you a better optometrist.